Hopefully all of you can see Dr. Y on your screen. She's up at the top for me. And many of you may know Dr. Y already, but in addition to leading LA Best Babies Network, Dr. Yonekura, is the Director of Community Benefits for Dignity Health, California Hospital Medical Center. Dr. Yonekura is an Associate Professor of Clinical OBGYN at both USC and UCLA, with a research focus in infectious disease in OBGYN and perinatal substance use. She continues to oversee Operations for Recovery, Harbor South Bay, the comprehensive perinatal substance abuse treatment program she established over 20 years ago at Harbor UCLA Medical Center. Over the course of her career, Dr. Yonekura has received numerous awards for teaching excellence and has been recognized at the local, state, and national levels for her service to the community and for the programs that she directs. As an expert on the topic of perinatal substance abuse, she is the perfect speaker for today's webinar, which will focus on recognizing and understanding the impact of substance abuse, identifying potential treatment options, and learning strategies for sharing treatment options with families in a non-judgmental way. Please join me in welcoming Dr. Yonekura as she presents this webinar on perinatal substance use and abuse. Welcome, Dr. Y.
Thank you, Martha. Good morning, everybody. It's a pleasure to be here with you talking about one of my favorite subjects. And in terms of disclosures, as Martha said, I run Options for Recovery. It's on the campus of Harbor UCLA Medical Center, and I established it way back in 1990, before many of you were probably even born. And it was at that time one of the first and only perinatal treatment programs in LA County, and one of the few in the country. So in addition to some of the things that Martha mentioned, we're going to talk about the use of non-stigmatizing language, which is very important for your particular role. How to screen and identify women with substance use disorders, how to triage them to appropriate services, and I'm going to spend the bulk of the time going over the impact of individual substances of abuse, including alcohol and tobacco, which we often don't talk about in our eagerness to talk about what's new. But I think these two old things are on the rise again, particularly in the wake of this pandemic. So I think it's important to talk about them. So what is addiction? It's a chronic, relapsing brain disease that's characterized by compulsive drug seeking and use, despite harmful consequences and long-lasting changes in the brain. And as you can see on the right-hand side, the upper graph, the relapse rates for drug addiction, shown in light blue, are very similar to the relapse rates for common chronic conditions like type 2 diabetes, hypertension, or asthma. We all know it's very common for people who are diabetics, who have type 2 diabetes, for example, to go off their medication or to not follow their diet. Similarly with hypertension and asthma. So, and we don't, get furious at these people for having stopped their diet, although we counsel them that it's important to continue. So I think we need to adopt a similar take with addiction, that it is a chronic and relapsing brain disease, and we are going to have to expect relapses. That's part of the disease process. For example, with tobacco, it takes often 7 tries to quit before a person is successful. So Nearly all addictive drugs take advantage of the brain's reward system by flooding the circuits with dopamine, as shown in the lower diagram. And dopamine, as you know, is part of our reward system. So the more dopamine, the better we feel, the more likely we are to repeat a particular behavior. So with the DSM-5, they changed from talking about substance use dependence and abuse to substance use disorder. And a substance use disorder is defined as having two or more of those bulleted symptoms in the past year, resulting in distress or impairment. And the more bullets that you have, or that the patient has, the greater the severity of the substance use disorder, categorized as mild, moderate, or severe. So as we all know, stigma is discrimination against an identifiable group of people. And there's a lot of stigma towards people with substance use disorders, and many inaccurate or unfounded thoughts or beliefs about them. We now know that addiction is a chronic and treatable brain disease from which patients can and do recover and continue to lead healthy lives. And if a patient identifies that she's being stigmatized, this will decrease her willingness to seek treatment or trust that particular provider. So it's important to show empathy towards these patients and to recognize that they have a brain disease. So as I mentioned, it's important to use person-first language, shown over in the green column, a person who uses substances rather than as an addict or a substance abuser. This changes our attitudes toward the person as the person has a problem versus the person is a problem. Okay, so that's really important, and we do the same thing with people experiencing homelessness, etc. So recurrence of use is preferred to relapse. Pharmacotherapy is preferred to medication-assisted treatment, although there's still a lot of use of that, because we all, for short, we talk about MAT services, it's just easier. Accidental drug poisoning rather than the word overdose. And again, a person with a substance use disorder rather than an alcoholic or an addict. So who should we screen for perinatal substance use? Why should we screen? It's to identify somebody who's using during pregnancy in order to improve both maternal and fetal health by linking them to appropriate services and supports as early as possible. And women are never more likely to accept treatment as they are during pregnancy. So it is truly a golden opportunity to change the life course of 2 generations, both the mother and her child, and probably if she has other children, her other children as well. We should be screening at the first prenatal visit and in each trimester, including postpartum. And we should screen, as I said, all patients. Nobody is immune from this disease. And we should screen using a validated screening tool. So I like to start with what's called the 5 Ps. This was developed by Dr. Hope Ewing up in Contra Costa County way back in the 1980s. And you get a lot of information by using this particular screening tool. Did any of your parents have a problem with alcohol or drug use? You get a sense of what was it like for that woman when she was growing up. Does your partner have a problem with alcohol or drug use? Women are often introduced to drug use by their male partners. Do any of your peers have a problem with alcohol or drug use? In the past, have you had difficulties in your life because of alcohol or drug use, including use of prescription drugs? And since you became pregnant, have you used alcohol or other drugs? And when you're going through this, you're actually gathering a lot of information about that your particular patient's life, her current, her past, and that's very helpful going forward because it identifies areas where you may want to probe more deeply, and I'll go through that in a minute. Any yes should trigger further questions. I follow the 5 Ps with the NIDA quick screen, which is available for use on the computer. And in fact, it will score the screen for you. So that's a handy thing to know about. Start out with this simple screen about alcohol, tobacco, prescription drugs for non-medical used for non-medical reasons, and illegal drugs, including marijuana. So if a person answers yes to 1 or more days of heavy drinking, she is at risk. She's an at-risk drinker, and we'll talk about that in a minute. If she says yes to any tobacco use, we should obviously advise her to quit. Same with drinking, of course. And if the patient says yes to use of illegal drugs or prescription drugs for non-medical reasons, then we proceed to the NIDA modified assist, which is also available on your computer. And again, it's self-scoring, so it makes it handy. So after you gather this information, in the spirit of SBIRT, which is screening, brief intervention, and referral to treatment, patients who screen positive, again, should be provided with non-judgmental information about continued use and its impact on themselves and their fetus. And they should be referred to appropriate treatment. Obviously, if they're postpartum, then you talk about the child instead of the fetus, but nevertheless, they should be referred promptly to treatment. Additional questions that are are helpful and guide treatment selection include their pattern of use, the route of administration, the quantity that they use, any additional symptoms they might have, and then importantly, any prior substance use treatment attempts and how long were they able to be abstinent, and were they using any 12-step programs after they finished their drug treatment program, or if they finish their drug treatment program. You might have noticed that I didn't talk about lab testing. In general, we don't use universal laboratory testing to identify those who may be addicted to drugs or alcohol. Because of its limitations, it only gives you a window of what has happened, perhaps in the last few days, couple days, depending on the half-life of the drug involved, rather than a comprehensive picture of what the patient is actually using. If you do order a urine tox screen, then it's important to get informed consent prior to testing. We only do it without informed consent if the patient is unconscious or obviously too intoxicated to give an informed consent, and the results are needed for necessary medical treatment. Some possible reasons for using a urine tox screen may be are shown here and include some presentations perhaps to OB triage, such as having an abruptio placenta. That's the premature separation of the placenta from the uterus. As you know, idiopathic preterm labor, idiopathic fetal growth restriction. In the office, it might be frequent requests for prescription drugs and saying, well, I'm allergic to codeine, so I really need something a lot stronger than codeine, like Percocet or Oxycontin. Non-compliance with prenatal care or unexplained fetal demise. Now, this is an important slide to think about. We also should consider screening for comorbid conditions. In my experience, the vast majority of patients have concurrent psychiatric illnesses. And this is more of an issue now in the wake of the pandemic than it was before the pandemic. So co-occurring conditions, mental health conditions, are common. They occur in like 50 to 65% of those women who are have a substance use disorder, especially depression, anxiety, and PTSD. So this is why during treatment, we usually refer women for concurrent mental health counseling because they need it. And they may need medication to address, for example, depression or severe anxiety, panic disorders. We should also screen for ACEs, adverse childhood experiences. One large study demonstrated that those with a history of 5 or more adverse childhood experiences were 7 to 10 times more likely to report illicit drug use and addiction. And in my professional experience with my patients, I'd say close to 90+% were sexually abused as children. And the reason they started using alcohol and drugs was to really drown those memories. So it's really, they have PTSD as a result of their ACEs, and that's why they started using. And so again, it's once they become sober, they have to have learned alternative coping skills in order not to go back to using again. Another thing we should screen for is intimate partner violence. Again, a very common co-occurring condition in this particular patient population. And again, a reason that many women continue to use drugs or alcohol because of this problem in their personal life. So how do you refer a patient for services? Actually, LA County has made it extremely easy for you to refer. There's one toll-free number. It's called our Substance Abuse Service Helpline, or SASH. 1-844-804-7500. There's somebody available 24/7 to get the call. So it's best to have the patient call, because what will happen is the person who picks up the phone will do a brief assessment over the phone to identify the program that might meet the needs of your particular patient. And then we'll send the referral directly to that facility. Each night, we have to identify whether or not we have openings. If we don't have openings, then they won't send a referral. So this prevents patients having to wait excessive periods of time to get into treatment. So that's very helpful. And again, the call agent can help determine whether your patient needs inpatient treatment or outpatient treatment, or pharmacotherapy if she's addicted to opioids, etc. So again, a very simple process. To find providers, you can also go on to the SAPC online directory with its address shown there in the second bullet. But it's best if you let the agent who picks up the phone identify the best place to refer the patient, because they know where there are openings. Now, who's eligible? Well, in LA County, almost everybody's basically eligible. The only person who's not eligible for these particular services are those who have commercial health insurance. And there are other ways to access treatment for those with commercial health insurance. But the vast majority of patients are eligible for Medi-Cal or My Health LA if they're undocumented. And so, again, they're all eligible. Medi-Cal, My Health LA, or any other county-funded program. But they must be a resident, obviously, of LA County, reasonable. So that's how you get them into treatment. What services are available, shown in the middle of the slide. Outpatient treatment, which can be intensive or less intensive, depending on how many times per week they come to treatment, and it could be residential treatment, inpatient treatment, could be medication-assisted treatment or in an opioid treatment program. I'll talk about that later. And what's important to also know and tell the patient is if she's currently homeless, which many of my patients are when they come to treatment, we have recovery bridge housing available for them. So while you can't sign the patient up perhaps for bridge housing, the drug treatment program can sign them up for recovery bridge housing once they're enrolled in the treatment program and continue to come for treatment. So that's a big benefit now. We didn't have that in the past, but that is available now. Okay. Any questions about how to access drug treatment using LA County's SASH hotline? No?
No
Martha?
questions, Dr. Y, but I just want to highlight in the chat that Steve let us know that the phone number is on the inside of the Welcome Baby book. So I will also send these slides out, but if you're looking for it, you can find it there as well. So thank you,
Great.
Steve and Amy, for putting that in there. That's great.
Yeah, that is great. So again, it's easy and very efficient. And usually we can get them into treatment within 1 to 3 days. So that's a big advantage. Okay, so let's talk about the natural history of pregnancy and substance use. The vast majority of pregnant women will be able to achieve abstinence from at least one substance by the end of the second trimester. Now, obviously, that's not ideal if their major addiction is to alcohol, but this is, in fact, a truism. When I began working with this patient population back in 1986, we were in the middle of the crack epidemic. And the head of the NICU requested that I do something because her nursery was drowning in preterm babies whose mothers had taken crack cocaine. So I started a special prenatal clinic for these women. And the only thing I knew how to do was to provide a lot of DLC. So we had them come weekly. And we had a nurse coordinator who was available to them 24/7 by phone. And again, by the end of the first year, the vast majority of my patients delivered drug-free. And the only thing we provided was TLC, literally. And, obviously, referrals to various things they needed. But other than we provided no medical intervention, no drug treatment intervention per se, and they were able to deliver drug-free at term, making the head of the NICU extremely grateful. So it's interesting that the majority of patients can abstain from alcohol, marijuana, and cocaine, but not necessarily cigarettes. Only 32% are able to achieve abstinence from cigarettes. And women that have an obsessive compulsive disorder or a generalized anxiety disorder are more likely to achieve abstinence than those with PTSD. And remember, the women with ACEs are more likely to have PTSD, and those are the women who are more likely to have difficulty abstaining. But in my experience, they too can abstain with the right supports. What about postpartum? Well, postpartum, 80% of women who were abstinent in the last month of pregnancy return to using at least one substance within 2 years of delivery, if not quicker. And they're more likely, as you would guess, to relapse to cigarettes, alcohol, and marijuana than to cocaine. So that's very interesting, and certainly goes along with the experience that I had way back in the 80s. And women with major depressive disorders were more likely to relapse than women without a diagnosis of depression. So again, what this emphasizes is that the comorbidity of a mental illness really impacts the ability of a person to abstain and also to not relapse. So again, emphasizes the importance of getting women not only into drug treatment, but also into mental health therapy as soon as possible. Okay, so from now on, I'm going to talk about individual drugs of abuse, recognizing that the vast majority of patients tend to be polysubstance abusers, but it's really easier to talk about the drugs individually than to it's impossible to tease out the individual differences from polysubstance use. Okay, so in terms of terminology, we said earlier that risky use is defined as alcohol consumption that puts an individual at risk for health consequences, but doesn't meet the criteria for alcohol use disorder. So this is more than 7 standard drinks per week on average, or greater than 3 drinks on any day. So what's a standard drink? That's shown in the little picture at the bottom. 12 ounces of regular beer, 8 ounces of fortified malt liquor, 5 ounces of typical wine, or a shot of distilled products. So that's what a standard drink is. It's not a tumbler full of vodka or some of the drinks of wine that you can get at a restaurant, which are actually 2 to 3 times the amount of a regular or a standard drink. Okay, so have to be clear about what a standard drink is. Binge drinking is defined as drinking so much within a 2-hour period that your blood alcohol concentration reaches levels of 0.08 grams per deciliter, which is approximately 4 standard drinks for women. And that's, the drunk driving level as well. Heavy alcohol use is binge drinking on 5 or more occasions per month. And alcohol use disorder is defined by a number of characteristics in the DSM-5 code. And unfortunately, despite there being placards at every bar and every restaurant that women who are pregnant should not drink alcohol, we are seeing now more and more women drinking alcohol during pregnancy. And in a CDC study back in 2015 to 2017, nearly 4% of pregnant women reported binge drinking in the past 30 days, and nearly 12% reported any alcohol consumption during pregnancy. So, and again, I want to emphasize that in the wake of this pandemic, there were 2 things available: alcohol and marijuana. And in my drug treatment program today, I am seeing more and more women coming to treatment addicted to alcohol and marijuana. So again, I want to emphasize, we expect this to be a much bigger problem today than it was in the past. And that's really terrifying. As you know, there is no safe level of alcohol consumption during pregnancy, period, exclamation point. Now, you will often hear from patients, well, my friend Susie drank throughout pregnancy and her baby is fine. What she's defining as fine may not be exactly fine, but at any rate, we have to recognize that there are women have different clearance rates of alcohol. Some of this is, and most importantly, women of color, particularly American Indians and African Americans, and Asians, Americans like myself, have much slower alcohol clearance rates than white women. So if I went drink for drink, if we had all these women lined up at a bar and we went drink for drink with a white woman, at the end of the time period, we measured alcohol clearance rates for each person. The clearance rates would be longer for women of color. Now, why is this important? That's what the fetus sees. And remember, the fetus has similar enzymes. It's alcohol dehydrogenase deficiency is what the problem is. And the fetus, we don't know what the fetus's enzymes are going to be like. We know that early they're not as well developed as they are later, but nevertheless, he's going to share some of the deficiency of the mother. So, and each fetus is different. So you could have twins and one could be more affected than its mate. So it's hard to assess the impact on fetal development because of all these variables that I've listed. but I want you to recognize that that women of color are particularly, their children are particularly high risk. And it's not because they necessarily drink more, it's they don't metabolize as efficiently. And then the fetus is exposed to higher levels for a longer period of time, and that's what causes the problems, okay? I hope I made that clear. Alcohol is clearly a teratogen, and it causes irreversible central nervous system effects that impact fetal growth and development at all stages of pregnancy. Because you know that the brain in particular keeps growing all through pregnancy and beyond, okay? So there was a very nice talk on Monday about fetal alcohol spectrum disorders. I encourage you, some of you attended that talk, and I encourage the rest of you to review the slides and materials that the speaker sent out. It was an excellent talk. And if you as a group would like to have that talk repeated, because it was not recorded, then just let Martha know that in your evaluation. So what's the impact of fetal alcohol spectrum disorders? It is currently estimated that 1 in 20 US school children may have FASD, fetal alcohol spectrum disorder. This is based on a really nice study in JAMA that I've cited up there in 2018. And I encourage you to read that paper. And what's depressing for me is that based on what has happened during this pandemic, we expect this rate to increase dramatically. So that's problematic. People with fetal alcohol spectrum disorder experience a mix of problems, including low birth weight and growth deficiencies, problems with their heart, kidney, and other organs, and damage to parts of their brain, which leads, unfortunately, to behavioral and intellectual disabilities, which are lifelong. They have learning disabilities and low IQs. They tend to be hyperactive, have poor attention span. So they're often misdiagnosed as having just ADHD, but they have problems beyond just ADHD. They often have trouble communicating in social situations, very poor judgment, poor reasoning, impulsivity, etc. In terms of lifelong issues, they have problems with school and social skills. It is highly unlikely that they will be able to live independently. They should live in a sheltered situation for the rest of their lives so that they don't end up in jail or homeless. They tend to have mental health problems, substance use disorders. They often can't keep a job. If they work, if ideally they work at a sheltered workshop and live in a community where they can be overseen, because they have trouble managing their money. and people take advantage of them. And because of their impulsivity, they often get in trouble with the law. For example, a common problem is Johnny sees a bicycle. He says, "Oh, I'd like to go for a bicycle ride." He hops on the bicycle, not thinking about the fact that that belongs to somebody else. He rides off on the bicycle, and then he's determined to have stolen the bicycle and ends up in jail for that, or in juvie hall as a youngster. This is very common. And so a lot, when we look in our jails and juvenile halls, we see a lot of individuals that actually have FASD as an underlying problem that led to them ending up in that facility. What about the effect of alcohol on breastfeeding? Breastfeeding women are likely to return to alcohol drinking. So this may come up. While less than 2% of the alcohol dose consumed is transferred in her milk, it's not stored in the milk, so that's good. But it takes a while for it to be cleared. So it's recommended that lactating women should not nurse for several hours after drinking alcohol. Alcohol does inhibit lactation, and this results in modified feeding patterns by the infant and shorter sleep periods. So if anything should discourage a woman from drinking during breastfeeding, it's that. The baby will have shorter sleep periods and she'll be up more often. It can result in affecting gross motor development and early learning in the child. Like in pregnancy, there is no safe level of alcohol consumption while breastfeeding, so it should be discouraged. Okay, now we're going to turn to something that's almost never talked about, but is again on the rise again. A lot of very anxious people turned to cigarettes during this pandemic, and cigarette purchases have gone up significantly since just like alcohol, since the beginning of the pandemic. Prior to the pandemic, about 1 in 14 pregnant women who gave birth in the United States in 2016 smoked cigarettes, but it varied widely by state, from as high as 25% in West Virginia to only 1.6% in California. And that's fortunate. And it varies by age, race, ethnicity, and education. Again, we should screen all patients for use of tobacco products and educate them and their partners about the consequences of tobacco use on both the mother and the fetus. It actually results in decreased fertility, increased risk for ectopic pregnancy. That's pregnancy that develops outside of the uterus, usually in the fallopian tube. Interestingly, decreases the risk for preeclampsia, but increases the risk for gestational diabetes. And sadly, lung cancer is the second leading cause of death in women aged 25 to 39. So that's very young to be dying of cancer. but it has terrible impacts on the fetus. 50% increased risk of stillbirth, 2.5-fold increased risk of preterm premature rupture of membranes, significant increased risk for low birth weight, over a 3.5-fold increased risk for placental abruption, an increased risk for preterm birth, especially before 32 weeks gestation. So those are the smaller preemies. Slight increased risk for miscarriage. And what's not discussed very often, there are some congenital anomalies associated with tobacco use during pregnancy, shown here. In the newborn nursery, the baby will appear stressed and hypertonic, very irritable and excitable, and this is dose dependent. And there's a 20% increased risk of neonatal death. Cigarette smoking has a negative impact on milk production, with lower fat concentration and lower volume. And so consequently, these women tend to not breastfeed for as long a period of time. It also increases the risk for sudden infant death syndrome twofold, respiratory infections such as bronchitis and pneumonia, short stature, childhood obesity, lower reading and spelling scores, and lower late adolescent executive function. We often see conduct disorders in boys and early onset drug use in girls. There's a 60% increased risk of ADHD. And again, this is dose dependent. Increased risk for asthma, type 2 diabetes, probably related to obesity, and Tourette's syndrome and other chronic tic disorders. So now we'll turn toward to marijuana use during pregnancy. In a 2017 CDC study, noted that about 10% of women reported using marijuana during prior to pregnancy. About 4% continued to use during pregnancy, and 5.5% used after pregnancy. And again, this has gone up significantly since the legalization of marijuana. And again, remember that marijuana dispensaries were open during the pandemic. They were considered essential services for reasons that have elude me, but so be it. And that's what, so the 3 legal drugs in California, at least, alcohol, tobacco, and marijuana, were heavily used in anxious people during this pandemic. And so we see a lot of this problem now in treatment. The most common reasons that women say they use marijuana is to relieve stress or anxiety, for nausea and vomiting, and to control pain. 32% of pregnant women who use marijuana during pregnancy are using it daily or almost daily. And that's very significant. How are they using it? Well, they're smoking it, eating it, dabbing it, drinking it, using it other ways. Okay, so let's talk about the THC levels. Back in the day when there were hippies, I'm sure you weren't born then, but I was, because I grew up in Berkeley, sort of there. There were a lot of them in Berkeley when I was growing up. And, you know, they were all smoking marijuana. Well, the amount of THC in the marijuana back in those days was about 1 to 2% if you were lucky. And it was 50-50 THC and cannabidiol, which is, cannabidiol is used for therapeutic purposes nowadays, but it tends to decrease the effect of the THC. Now they have bred cannabidiol out of the marijuana plants that are used for smoking. And the amount of THC on average runs at least 25% on the street. And they have contests every year to see who can breed a higher THC concentration in the plant. Okay, they have contests. And so we see plants with 35 to 40% THC. This is a different beast than it was back in the 60s. Eating. Well, there isn't really great control in terms of the amount of THC in a particular edible, especially edibles sold on the street. While it is recommended that one not use more than a certain amount of like 5 to 10 milligrams of THC in a particular product, what they do is they say, well, you just eat one piece of the candy bar, and that's 5 to 10 milligrams, and the whole candy bar is multiple times that. So if a naive person eats the whole candy bar, they can end up quite ill and in the emergency room. Dabbing. Dabbing is heating up what's called butter, which is a glob of honey-like, it looks like honey-like marijuana with a blowtorch often, and smoking that. And the THC concentration in dabs runs around 80 to 90%. 80 to 90%. Okay, so. And the beverages have all kinds of concentrations, going very high. Okay, so physiologic signs. Classic is the red eye. The conjunctiva is red. Looks like you have bloodshot eyes, but it's because of the cannabis. And you get what they want is the euphoria and relaxation. But they can have undesirable effects of paranoia and present to the emergency room with a variety of symptoms, including psychiatric problems, often psychosis, cardiovascular problems like chest pain, palpitations, and then particularly problematic is cannabinoid hyperemesis syndrome, where they can't stop vomiting. This is usually with synthetic marijuana, and the only thing that relieves the symptoms is abstinence plus hot, very hot showers and baths. So in terms of symptomatology, persistent symptoms usually resolve. Neurocognitive symptoms resolve within a few days, but you can have chronic mood changes. Those adolescents who do chronic cannabis use often end up with psychosis and go on to develop chronic schizophrenia. What's the impact on pregnancy? Increased miscarriage, stillbirths, neural tube defects, perhaps preterm birth, clearly low birth weight. And what's most important is that THC interferes with neural stem cell survival and proliferation, migration and differentiation, and neuronal connectivity and synapse formation. So basically, the cells don't connect to where they're supposed to connect to in the brain if they're exposed to a lot of THC. So I think of THC as a neurodevelopmental teratogen, a neural developmental teratogen. In the newborn, we see exaggerated motor reflex, more tremors, altered sleep pattern, increased irritability, and increased muscle tone. These kids are so stiff they can stand as newborns. Uncoordinated suck-swallow reflex and thermoregulation instability. Long-term, and this is based on 3 longitudinal studies, one of which is still ongoing. Early on, we see increased aggression and attention deficits. 3 to 6 years, problems with verbal reasoning, visual reasoning, short-term memory, hyperactivity, attention deficits, impulsivity. 9 to 10 years, critical school age years, problems with executive functioning, reading and spelling, hyperactivity, attention deficits, impulsivity, and then we start getting depression, anxiety problems. And going on into adolescence, we end up with poor academic achievement. This is when most of the kids start dropping out of school. They become delinquent and start using drugs and alcohol. Late adolescence, early adulthood, again, problems with executive functioning, addiction, and so forth. So again, this is a neurodevelopmental teratogen. I've been saying this for a long time, but the California Office of Environmental Health Hazard Assessment declared in January of 2020 that cannabis and THC were clearly reproductive toxins. So that made it clear. Okay, what about breastfeeding? Oh, this is a big problem because THC is in higher concentrations in the breast milk than it is in the mother's plasma. So the milk to plasma ratio is 6:1 on average. Takes about 17 days, plus or minus 3, to totally eliminate. It takes a total of 6 weeks to totally eliminate. So the estimated half-life, is 17 days, and it takes about 6 weeks to totally eliminate THC from the breast milk. THC accumulates in breast milk because it's fat soluble. And there's a lot of fat in breast milk, as we know. And so therein lies the problem. So it's not recommended to use cannabis during breastfeeding. On to opioids. Opioid use disorder has increased significantly in the United States. In particular, in 2019, 7% of women reported using prescription opioid pain relievers during pregnancy. And so we're seeing a lot greater problem. And nowadays, a lot of heroin is contaminated or adulterated with fentanyl, which is 50 to 100 times stronger than morphine and results in death more frequently. So we see a lot of problems for the baby, including preterm birth, low birth weight, respiratory problems, feeding problems, and then we have a lot of maternal mortality because of fentanyl adulteration. So again, a lot of patients start using prescription opioids. When they can't get a hold of those anymore, they turn to heroin. They may at first be able to maintain a job, but ultimately they end up impoverished and often using various illegal behaviors such as shoplifting, burglary, prostitution to support their habits. So while a patient started using this drug to make them feel better, in the long run, all they're doing is trying to escape withdrawing. If you ask an opioid addict, why do you continue to use? It's because they don't want to go into withdrawal. So how do we manage pregnant women? We get them onto pharmacotherapy as fast as we can. The ACOG committee opinion is very clear. They don't recommend withdrawal from opioids because most of those patients will go on to relapse, and that's ultimately worse for the fetus. So get them on to pharmacotherapy, opioid agonist pharmacotherapy, and have them maintain that during pregnancy and postpartum, and for as long as they might need, which might be a very long time. There are two main drugs, methadone and buprenorphine. Methadone requires that the patient goes to the opioid treatment program daily, usually at 7 o'clock in the morning, to get this is a liquid dose of methadone, whereas buprenorphine is a pill that can be dispensed and taken in the privacy of her home. However, there's a higher attrition rate or relapse rate from buprenorphine compared to methadone, 33% versus 18%. So that's why a lot of us prefer methadone, particularly for somebody who's been on opioids for a long time. The other problem, as you're aware of, is neonatal abstinence syndrome, now known as neonatal opioid withdrawal syndrome, NOWS, has replaced NAS. It favors buprenorphine because most of those babies will require almost no treatment whatsoever. And I always encourage my patients who are not HIV positive to breastfeed while on their pharmacotherapeutic medication, because there will be a transfer of the medication to the newborn, and that helps, again, decrease the withdrawal syndrome. So these are the drugs that can be used. We tend to focus on methadone and buprenorphine as the two primary drugs used. And we give the patients naloxone to take home in case they or somebody they know goes into respiratory arrest from opioid use. So shown at the top there is the fatal dose of heroin compared to fentanyl. Fentanyl just takes a few grains of fentanyl to cause a fatal overdose. So that's why you hear stories in the press all the time about, and there were just 3 people recently, I think 3 comedians who overdosed on I think cocaine or meth and fentanyl, and 2 died and 1 lady was fortunate to survive. So unfortunately, a lot of the heroin that's coming into America is adulterated with fentanyl nowadays. These are some of the different treatments used in addition to pharmacotherapy. We use these other methodologies as well. Okay. And in the long run, patients should get involved with peer support groups such as Narcotics Anonymous, Methadone Anonymous, or some such program, because that's going to help maintain them in the long run, just like Alcoholics Anonymous works for alcoholics. And there's a national perinatal maternal safety program involving care for women with opioid use disorder. If you want to read about it, here's the reference. Okay, on to stimulants. So the most common stimulants are cocaine and methamphetamine. As you're aware, cocaine blocks the dopamine transporter system so that dopamine remains in the synaptic gap longer, and therefore has more of a positive impact. With respect to amphetamines, it blocks the dopamine transporter like cocaine, but it also stimulates a flooding of that synaptic gap with dopamine. So it causes a much greater and more prolonged high. The impact of cocaine on pregnancy, it causes preterm birth, low birth weight, and increases placental abruption, and causes the baby to be a bit shorter and have a smaller head circumference. Meth is on the rise worldwide. It's very common in California, not so common in some parts of the United States, but certainly in our part of the United States, it's very common. It used to be made by motorcycle gangs up in the high desert, but the precursors were taken off the market. So now it's almost all made in super labs in Mexico, and then gangs bring it into the United States. The majority or many of these patients have comorbid psychiatric disorders. So it's important that they are screened and referred appropriately for mental health services. Meth is extremely addictive. Often, meth users become addicted after the initial use. It's that addicting. The amount of dopamine that's they're exposed to is so high that, you know, it's something they'll continue to chase. So you can see the cycle. We see cycles of intense binging followed by sobriety and then more binging. In terms of what its impact on pregnancy is, again, preterm delivery, preeclampsia, abruption, and severe maternal morbidity and mortality. Again, a lot of the methamphetamine nowadays is laced with fentanyl, and that's what we're seeing as the predominant cause of death in California. So as I said, it causes growth restriction, decreased weight, length, head circumference, and we often see various congenital anomalies such as cardiac, cranial, and some of the abnormal brain development will resemble that of ill asphyxiated infants. Because remember, this is a powerful vasoconstrictor, very powerful and has a long half-life. It has an impact on breastfeeding, but because it has such a long half-life, in these two patients, its half-life varied from 11.3 to 40 hours. It takes about a day for it to disappear. Before the urine becomes negative. So if a mother is in fact abstaining, and you know that, then she could breastfeed after her urine test turns negative. But if she's still using, she shouldn't breastfeed. There is a prospective study ongoing called the IDEAL study, which involved Harvard UCLA. So many of our babies are in this study. 17% were admitted in NICU because, again, premature, low birth weight, having various problems. And what's important to realize is about half of these babies will end up with Child Protective Services, DCFS in LA. They have poor fine motor performance at age 3, modest decreased height at age 3. Between ages 3 to 5, we start seeing problems with them having increased emotional reactivity, more anxious or depressed, often externalizing behaviors, conduct disorder, attention deficit disorder. And these types of problems continue on into age 7. This is a follow-up at age 7. So a number of symptoms at that point. And again, they suffer a lot of changes of primary caregiver. They're in foster care, the foster parent can't handle them, and they end up going from foster parent to foster parent, or from grandparent to foster parent, et cetera. So it's very disruptive for them, and they end up being very unhappy children. So it does cause, as I said, problems with, it's a neurotoxin, and damages certain parts of the brain where there are dopaminergic synapses and serotonergic synapses. So those are the areas we look for, and we see problems in these kids. So in sum, all the drugs of abuse, including the 3 legal ones, alcohol, tobacco, and marijuana, cause various problems for the developing fetus. And this is a very nice review paper that I direct you to in neuropharmacology that talks about the different impacts that we've gone over today. So we're almost at the end of time, but if you have any questions, I'd be happy to entertain them. And I can stay later for those of you that have to leave. Good day to you, and thank you for your attention. I hope this was helpful. If there is anything you need with respect to this topic, please let me know. I'm always available to help, and would be happy to see any of your referrals at my drug treatment program in Harvard. Thank you.
Thank you, Dr. Y. That was a really, really informative talk. I think everybody really appreciated it. So thank you. Let's all give Dr. Y, I see some people doing it already, a round of applause. I have a couple of questions that came through the chat, and then I would encourage anybody else who has questions to feel free to type them in the chat, or once I'm done reading the one that came through, you can unmute yourselves too and share. So the one question that came through, let me find it where I wrote it down. Okay, so when we were talking about the pregnant women at your clinic who had a weekly meeting, you mentioned that you had given them TLC, and the participant was wondering what exactly that encompassed. Was it like reflective listening, or was there more to it than that?
That's before I even knew what reflective listening was. But what we did basically was we did listen to them. And what I said to the women was, I'm trying to set up this program to help other women like you, who are addicted to, in this case, crack cocaine. I need your help. I've never used crack cocaine. I don't know what services you need. Please help me. And so they basically co-built the clinic with us. We used only nurse midwives, all female, and because many of these women have been abused at the hands of men from the beginning of their lives to the current, to the present. So they basically co-built the clinic. So I was doing trauma-informed care before there was trauma-informed care, because I was listening to them. I was being responsive to what they asked for and said that they or others needed. You know, I think that was very empowering to them to basically co-build this clinic. Many of them volunteered to talk to new clients who are coming to the clinic. to encourage them to, stop using, tell their story, et cetera, et cetera. But it is a lot of reflective listening, walking beside them, not in front of them, doing with them, not for them, and being available, consistently available. 24, my nurse was available to them 24/7, literally. She was on the beeper to them. In those days, we had beepers. They knew that. And they knew they could call, they knew they could drop into my office upstairs and chat whenever they needed to. Sometimes that was after hours and we'd talk for, a while. A lot of them had, as I said, had terrible histories of early childhood trauma. Trauma that I told them, you are the survivors. You are the smart ones. The dumb ones died. I don't think I have your inner strength. I think if I had been faced with what you lived through as a child, I would have jumped off a bridge. I would have bailed out early. I am amazed that you're still here. And when they became clean and sober, they could turn their skills and their persistence, if you will, before they were pursuing the next high, now they were pursuing their education or job or whatever. A lot of these women went back to school, finished high school, and, went on to get good jobs. And we have reunions every 5 years. I have women driving all the way from St. Louis to come back to the reunion to talk with their friends and to say thank you. So, yeah, TLC, it's important. They knew we cared deeply. We were, after hearing their stories, we had a lot of empathy. In those days, we didn't have recovery bridge housing, so I had patients living in the dump in an abandoned car. But they thought that was good because the car door locked and they felt safe. So, they did what they had to do. But that's what I meant by TLC. It's what you all do now, because we know about trauma-informed care, we know about reflective listening, we know about motivational interviewing. You know all these things. I didn't know any of these things. I went from being an infectious disease investigator to focusing my attention on addiction and really not knowing anything other than I wanted to help. And I certainly could listen. I'm good at listening. And they told me what they needed. So that was helpful.
Thank you. That's a great answer. And I know we have another question, but I want to pause and just thank you for doing that work and recognize all the people you helped by doing that and all the people that have the potential to be helped by our home visitors by doing the same thing. Like you said, this is what they're doing now. So it's amazing to hear that story and hear about all the good things that you've been doing for so many years. I can't imagine all the people who've been helped by that. So thank you for that. I have one more question for you, and then I think we'll be pretty much done it. Again, if anybody has any follow-up questions, feel free to keep putting those in the chat. But Another question that came in is, what is the best response to say to a mom that's breastfeeding who still wants to drink alcohol? Because you mentioned about the alcohol staying in the breast milk for several hours. So what's the best advice and the best response for someone who's facing that?
Well, I would just tell her, that she's exposing her baby to alcohol, and that we know alcohol is a developmental teratogen. It's not good for the baby. It makes her breast milk, it will result in changes in the baby, such as sleeping shorter periods of time, which will make her life more difficult, right? Because she's going to be up more often. She should basically choose, which is more important to her, drinking alcohol or breastfeeding. If it's breastfeeding, then she should stop drinking alcohol. If it's drinking, then she should stop breastfeeding, because we have good formula products available. So, and the baby will do better, will be healthier if she gives the baby formula in that situation. So I would be very clear.
Great. I think that's really helpful. Thank you. I had one more that I came up with too. I'm wondering if you have any resources for that share. I know that last slide you had kind of had that picture with the effects of using different substances during pregnancy. But if you have any other like client-facing resources that you know of about how to communicate the effects and the potential risks, the alternatives, et cetera, do you know of anywhere we can find those, or do you have good resources that you use for your women that you work with?
I have a great one for alcohol, which shows a child at the chronologic age of 18 and what some of the differences are in terms of their, judgment, et cetera, what age equivalent they're stuck at. Based on that, I can pull that for you. Let's see. I don't have anything I can think of right off the top of my head that are necessarily patient-facing. There are a number of brochures, but I think I'll look for some infographics. I found a few, but not what I necessarily want. So, but I think, the thing I wanted to get across to you today is that the legal three, I call them, cause a lot of damage. And it certainly is not recognized by a lot of people that tobacco causes so many problems. When tobacco smoking was more prevalent, it was clear. But tobacco use in California has become somewhat rare. But be on the lookout. I want you to be on the lookout for both increased alcohol and tobacco and possibly marijuana use in the wake of this terrible pandemic, because people, the use of drugs primarily is to cope. Outside social situations where people are social drinkers, they drink at a get together or something. But these folks start using to cope with something. It's important to find out what they're coping with, because that's sort of the root cause of the whole problem. And, for a lot of my patients, it's ACEs. But I will look for something, Martha.
Thank you. And if anybody, any of the RNs on the call, if you use anything that's really useful, you can send that to me as well. I'll put my email in the chat. And feel free to send it. I'll make sure to include it. We'll put it on the blog and make sure all the resources, you're the ones doing this. So if you found something that's useful for you, whatever it might be, just feel free to share it with us so that we can pass along to all your peers too, and they can get the knowledge that you have. So I think that's it for our questions, but thank you so much, Dr. Y, for being here. This is really, really informative. Really appreciate all of your information and the time that you took to put this together for us. So thank you. If anybody has any questions or follow-up that you want to reach out to me or Dr. Y, feel free. I put the evaluation in the chat, so please fill that out. It helps us to plan better webinars for you in the future. So we always want to make sure to hear what you think about everything. And with that, I'll send out the recording and the slides and everything in the next couple of weeks. So be on the lookout for that. But that should be all. So thank you everyone for being here. Thank you, Dr. Y, once again. And I hope everybody has a nice rest of your day and a good rest of the week. Thanks, everybody.
Thanks for all the work you're doing. You're touching a lot of families in very positive ways.
Thank you. Bye, everybody.
Bye-bye.